preparation for our lab on Tuesday, you're going to be pre-watching my demonstration of digits, thumb, hand and wrist, and then during lab we'll go right into our practice mode. So in most of your clinical sites that you guys will be assigned to, you will still use some sort of image receptor, probably computerized radiography, but some institutions have direct capture. So whether or not they have a 10 by 12 cassette, you're going to be utilizing a field of view no larger than 10 by 12. And probably as small as 8 by 10 with additional collimation. So we're going to start with digits. So when you're doing these, they're done on the basis of the clinical site's protocol. Most places will do a PA of the entire hand, which shows a PA view of digits 2 through 5 and an oblique view of the thumb. Once you've done the PA hand, then you're going to do an oblique and a lateral of the affected finger. So I'll demonstrate the index finger, and then we'll move on into the thumb. So for this, most clinical sites, their x-ray table raises and lowers. Ours is in a fixed height. So I'm going to have to adjust my patient down to a level to make sure that his forearm and hand are on the same plane, because we don't want the wrist angled up like this. We want it flat. So I'm going to have my patient turn his chair sideways so that he can place his right arm out and have it be at a comfortable position. Now, because we're doing this tabletop, you're going to move the cassette into a position that's comfortable for your patient. So I wouldn't, have him move way out here or have him be at some odd angle. I would make sure that he's in a comfortable position, and then I'm going to adjust my cassette to him and then make sure that all of his fingers are flat on the IR and slightly spread apart, because we don't want to have tissue overlap with the fingers together. We want them spread apart comfortably, not hyper spread, but just at a comfortable position. If this is the right hand, I would place the right marker typically on the lateral side, and then I'm aiming to get my third metacarpal at the center of the cassette. So when I place his hand down, I'm visualizing this knuckle in relationship to the niches that are on the cassette. And so I've roughly got his hand positioned in the middle of the IR. And now when I position my x-ray tube, I'm also lining up my central ray to the third metacarpal phalangeal joint. In testing and in speaking, you can abbreviate MCP, but the full name is metacarpal phalangeal. So now you'll notice my collimation doesn't quite include everything. I want my collimation to go about an inch beyond the anatomy. So still my thumb is not included, so I'm going to open up slightly wider. Now I've got more collimation on this side than this side, so I may adjust slightly, but just remember that your central ray is going to enter at, for testing purposes, third MCP. So we're set up to go. I'm going to place our lap shield on our patient. Your SID is going to be at 40 inches. The tape is broken in this, but approximately 43 on the readout, because 40 would be in the table bucky. And we'll get to that later. But so I'm centered at the third MCP. This is a PA projection of the entire hand. I would expose this And then I would proceed on to do the oblique and the lateral of the affected finger. And in this case, it is his index finger. So I'm going to change out my cassette. I'm going to place in a new one. And now I am centering at the, instead of the proximal interphalangeal, or metacarpal phalangeal, I'm centering at the proximal interphalangeal. And I would oblique his finger approximately 45 degrees, trying to keep it flat on the IR and in a position that he's able to hold it himself. If there's difficulty, you can always put a positioning sponge underneath. Bend these fingers a little bit. Help me out here. Okay. Okay, so I'm at approximately 45 degrees. I'm going to readjust my central ray to the proximal interphalangeal joint, collimate down. Now I only need to include the affected finger, but I also need to include about 1/2 of the metacarpal. So I'm at 45 degrees rotation, placing my right marker. Some places will also want you to place a BB or an arrow that points to the affected finger, but that'll come at the clinical site. All right, so I would expose that. Some clinical sites may have you also do an external oblique, but you'll notice that there's some OID here, but in any case, normally one oblique is required. Okay, so we would do one or both obliques, and then for the lateral, there's a couple ways to do this. I would like you to fold all these fingers together and hold them with your thumb. Now, in this instance, yes, it is a lateral projection of the index finger. However, I've got a great deal of OID here. So to solve that, I'm going to, again, do something that's comfortable for my patient, which requires me to move my cassette out of the way. Okay, so now, rotated medially, his index finger is resting on the IR. Right, so I'll center to the proximal interphalangeal joint. Again, I'm getting about 1/2 of the metacarpal. I'm going to place my right marker, straighten this out just a little bit, and expose. Okay, so we're going to discuss how to accomplish obliques and laterals of all of the digits during your practice, but for the demonstration, this is the one that I wanted to cover. Now for the thumb. Now remember, when we did our initial PA of the hand, our thumb is at a 45-degree oblique. So the PA view is the oblique projection of the thumb. I still have to do an AP and a lateral. So I'll do the PA hand, centering 3rd MCP, okay, right marker, and then moving on, I would do my lateral and then my AP thumb. For my lateral, you're going to get the finger going down the long axis of the IR, and you're going to have him just bend the other fingers to sort of support the hand in that position, centering to, and again, now the thumb has a distal and a proximal phalange, so I'm centering at the only interphalangeal joint on the thumb. All right, the thumb is in a lateral position. I'm including 1/2 the metacarpal, collimating down, putting my right marker, and again, your clinical site may have you mark these as 1, 2, 3, 4. They may have some lead numbers or something that they want you to put in the field of view, but that's up to the protocol. Now you'll notice that his thumb is a little bit bent. I would ask him if it's okay for me to straighten this out. If they're in pain, then just do it as is. So that's our lateral projection. And then for the AP, this is difficult for some patients to do, but I find that if you just have them extend their arm directly out at a right angle to their body and roll over, they can pretty much get their thumb in an AP position. So right here is AP for him. So what I'm going to do then is, once I have him in the position I need him and he's comfortable, I will adjust my cassette to meet his comfort and his position. Again, I'm looking at the notches on my IR, and when I set the hand down, I'm going to try to match up where my central ray is going to go, so that I don't have to do a whole lot of adjustment after that. All right, so centering here, I would rotate my collimator so that it is lined up with the long axis. Place my right marker, make sure that the other fingers are out of the field of view, and I'm hoping to get the metacarpal phalangeal joint of the thumb. So I want to make sure that his fifth metacarpal is rolled out of the way while still maintaining an AP of the thumb. So sometimes you have to work with the patient a little bit on this one. It's not a quick exam like the others. You kind of have to work with them a little bit. So that is our AP view. If he had an elbow injury or a shoulder injury and was unable to assume this position, another option for the thumb is to do it PA with OID, but this is sometimes more comfortable for a patient who cannot roll their arm backward like this. You can do this in a PA position, and then what you would do is, to overcome the OID, is just raise your SID the same number of inches that his thumb is off the IR. Okay, so our right marker, I may also put a number 1 in here for first digit, and that is the PA thumb. Moving on to the hand series, we've already demonstrated our PA hand. And if a patient is uncomfortable at this, like I iterated before, you can move it to a position where they are comfortable and adjust your tube. But for purposes of our simulated evaluation and demonstration in lab, we're going to do it like the book shows, with the upper extremity bent 90 degrees at the elbow, and so the forearm and hand are on the same plane. So I'm centering to the third MCP for my PA. My right marker is in view, and now I'm going to move on and do an oblique and a lateral. So the external oblique is the only one that you have to do. You can utilize a finger sponge. I normally don't, but I will on patients who have trouble holding still. If they're injured, for instance, and they're shaking and they can't hold still, then you can utilize the stair-step finger sponge and place a finger on each of these stair steps, but you have to make sure that the hand remains parallel. If you have this angle down, this joint here is flexed, and that's going to close the joint. So if you utilize a finger sponge, make sure that you have the palm elevated as well, so that everything is on the same plane. So this is 45 degrees. If you don't want to use this stair step, you can also always use a 45-degree angle sponge and place the hand flat on that side. It depends on what your clinical site has available, the comfort of the patient, what you're comfortable with. So at 45 degrees, I'm going to center. Again, our central ray is passing through the third MCP. So I will center there, and I'm slightly off, so I'm going to adjust my cassette now so that not only am I centered correctly, but I'm also at the center of my IR. Now at 45 degrees and keeping everything lined up, This looks pretty good. I want to include the wrist joint, so I'm going a little bit beyond the styloid process. I've got my thumb in the field of view. I've got a good 1-inch margin around all the anatomy. My right marker is on there, and I would expose. For the lateral, this is the one, the book talks about doing a regular lateral and a fan lateral. The fan lateral is the only one that we're going to be demonstrating for our simulated evaluation, because in this position, I'm getting a lateral view of each one of the digits. The book also talks about doing a lateral hand like this, which superimposes all the digits. We do a fan lateral, so he would roll up onto his ulnar side, making sure that the wrist is straight. And then you want them to touch their finger and their thumb together, but not in an OK sign, because when the index finger is rounded, these joints close. So you want to keep the index finger straight and have them touch the finger to their thumb. And then one by one, you're going to bring out each of these individual digits till each finger is straight and unsuperimposed from its neighboring finger. Okay, so like this. I usually just hold the position that I want them in and then let go, and then I'm ready. I'm almost set. I should not have to do much adjustment after that. Throw my marker on and expose. Okay, when you're doing the lateral finger, especially the fourth finger, most people don't have any problem doing a lateral third finger, because at some point in your life you've probably given someone the bird. But the fourth finger is generally very hard to hold out by itself. And so in that position, I would have them fold their unaffected fingers forward as much as they could, and with the opposite hand, using a Q-tip, a tongue depressor, in this case we have a popsicle stick, you would have them put pressure on the affected finger to move it out into the lateral position, because it's very difficult to hold your fourth finger out by yourself. So that's just a little trick. And like I said, anything radiolucent, so tongue depressor, Q-tip, you could even utilize a sponge if you wanted to wedge a sponge in, and if you didn't have a popsicle stick, you could do something like this to single out that affected finger. Okay, so moving on to the wrist. So the book talks about the importance of having the forearm and humerus on the same plane. Once you get to elbow, absolutely you have to have the forearm and the humerus on the same plane. But for the wrist, as long as the elbow is touching, then I know that my forearm, wrist, and hand are all in the same plane. For the wrist, you're going to be centered about the level of the styloid processes. Normally those are visible without palpation, so when I set his hand down, I'm looking at this styloid process and I'm lining it up with the center, and I'm looking at third MCP and lining it up because my crosshairs here in the middle of my wrist should match up to the niches in the IR. So in the PA projection, the book talks about the arch of the wrist. So in this position with his hand flat, there's space under here, right? I meet no resistance. Once he tucks his fingers under and his wrist is arched, it stops. Now there's no space. So where there was a slight object image distance, by flexing the fingers, you arch the wrist slightly and you put it in contact with the IR. So I'm centering styloid processes. I'm making sure that he's comfortable. So if I need to bring this out a little bit, I can. But for purposes of our sim eval, we want everything lined up. You guys are going to get more comfortable moving the tube around as we go along, but for right now, we're gonna keep our IR squared up with the table. So our edges are parallel. And I'm gonna center at the mid-carpal area, which is at the level of the ulnar and radius styloid processes. I wanna get at least half of the metacarpals and maybe a fourth to a third of the forearm. I'm collimating down 1 inch on all margins to make sure that I've got room for my right marker. So that's our PA projection. For our external oblique, all I'm gonna do is roll him up 45 degrees. And again, you're just gonna have to get used to what 45 degrees looks at. We're not gonna use a protractor or anything to be that accurate, but you're gonna estimate what that halfway point is from vertical to horizontal. So his wrist at 45, not much difference in how we're positioning. We're still aiming at the level of his styloid processes and keeping our collimation the same. Now, for the internal oblique, and some facilities do not do this, but for the external oblique, what you would do is roll his arm outward. So we're doing a PA oblique at 45, and now we're doing an AP oblique at 45. So I'm adjusting this just because, you know, he was straining a little bit, 45 degrees. And in this case now, I am going to have to rotate my collimator head because I want my light field to be lined up with the long axis of his arm. Okay, so that is our AP oblique or external oblique. Okay, now to do a lateral, again, I'm going to make sure that at least his elbow and forearm are touching. I'm going to line up, I want both radial and ulnar styloid processes to be superimposed. So I'm going to get him in a lateral position, and then you actually slightly externally rotate, because what looks completely lateral has the radius and the ulna offset just a little bit. If we externally rotate, we tuck the ulna under the radius. So this is maybe 2 to 3 degrees external rotation. Right marker. I want my collimation to be with the long axis of his arm. Okay, that is my lateral. And when you're in the ortho department, the orthopedic surgeons and orthopedic PAs are very particular on lateral wrists. They want the ulnar and radial styloid process to be exactly superimposed. So if you do a little bit of external rotation and they're not superimposed, you might need to do a little bit more. But for our purposes, you need to remember radius and ulna styloid processes superimposed, and that it takes just slight external rotation to achieve that. Okay, now, one of the most commonly fractured carpal bones is the scaphoid, or navicular, depends on the textbook that you read. Because of the shape of this bone, we're going to use distortion to our advantage. So I'm going to have him extend his arm all the way out. Okay. And before I put him in ulnar deviation, I'm going to get everything set up. So for this, I want to be angled 20 degrees toward the elbow. Okay, so I'm looking at my digital readout here. I have 20 degrees of angulation. I'm centering at the level of his scaphoid, which we're going to talk about this in class. It's called the snuff box. If you extend your thumb up, you'll see that tendon right here. and there's a little crease right next to it that's called the snuff box area. That is where the navicular bone is. So that is my center point. Okay. So I have my angulation, I'm centered, I'm going to have my marker in here, and the last thing I do before I expose is I'm going to have him do ulnar deviation. So he's pushing his hand away, and what that does is draw the other carpal bones away from the scaphoid, and it just gets it in profile better. So this, by turning the wrist and by angling, we're using distortion to our advantage. All right, so that is our scaphoid view.